here at ADLO, together with Southern Africa Education Center and the Female Sex Workers Association of Malawi, we engaged different coordinators managing HIV prevention, treatment and care to understand how severely affected they've been after the funding cut, especially from the public health service provision perspective. So they shared a lot of saddening and also disheartening things, one of them being the pressure that has now been exerted on the public health facilities, that so many people are now trying to access services, but the services are not enough. They are often running out of stocks, and also the personnel that were being receiving funding or receiving support from the USAID and also other US government institutions like PEPFAR have also stopped providing those services. So in an office that could have 3 or 4 employees, only 1 employee is there to provide services.
The staff from MH, I think we were reluctant, not necessarily we weren't know what we were supposed to do, but we were reluctant after stopping order. Most of the services were provided by the partners in our facilities. So the gap was shown mostly to the first 95, where we were talking about the HTS, but not necessarily we didn't have the providers at the facility. We do have, because we do have the disease control surveillance that almost 3/4 of these personnel were trained before, and we are providing. But because of the presence of our partners, I think they were focusing more on testing, so then they resume to other duties because they are community-based. So with the stop order in some other facilities, because we had a directive and we had to work at the facility level, how we can cover this situation by retrieving back those who are working to the community to have a facility to provide testing because of working stop order. And in relation to sales, only area that are affected is in relation to provision of those ARTs. And we do have trained providers from MOH, and it wasn't affected much because it's a facility based, and all the clinicians and nurses are also working at the facility level. So it was easier to cover up the gap which was there, mostly to all the facilities that left the services provided by the partners.
You have your drop-in centers. I assume the LGBT community access them as well. If your drop-in centers, at the time when there was the stop work order and people were referred to the health facilities, was it as possible, for example, for some of those groups to access the health services? And if things change, do you think there might be some groups who are going to fall through the cracks?
I think we had the orientation done,
yes,
that how we can handle such individuals when they come to the facilities. So some of the facilities we do have focal persons that can handle such people.
As soon as the funding cuts happened, the South Africans started chasing away the foreign nationals from the clinics to say, listen, there's not enough for everyone, we're chasing people away now. So I'm just asking, do you have like similar situation here?
No, we do provide service to everybody. We don't choose, because we are not using IDs, so we can't say, we are not the immigration officers, so we accept everybody to get the service.
Okay.
Yeah.
And so when we spoke to the Lewonde people yesterday, they were saying they were told that they need to stretch their medicine as far as they can, and because they're not necessarily sure of sufficient supply all the time. Did you get any of those sort of instructions?
I think that communication was made, I think for the first supportive supervision we had for national supportive supervision, whereby the communication was focused on most of those who travel abroad. All right, we can give a supply of a year, but what we requested to those individuals to come to the facility to get their viral loading collected samples. That's the only binding principle that we are there. So if they manage to come every year to get tested and go back, we don't have a problem, we can continue supplying the medication. But if they fail not to come to get their viral load collected, we can't provide with the medication to the guardian. unless the owner comes to the facility, because we have to know the issue of separation in relation to the law. So that's the current circular is saying, and is what we are following.
Those hotspots, going to those hotspots was very, very
easy,
critical and necessary, and NGOs were filling that gap. And that's what worries me, that if NGOs don't have the money to go to the hotspots where the sex workers are, where the undocumented people are, where the young girls are, that's where people are going to get lost in the cracks. Because obviously healthcare workers and nurses can't go to the facility because she's not one of us sex workers. You know, the sex workers feel more comfortable if it's one of them coming to them or bringing them to the facility. For me, that's where the gap is and will continue to be. And that's what PEPFAR and USAID was helping with. To what extent are our governments, I'm not just talking about Malawi government, going to be able to fill that gap when that fund is completely cut? Because we are certain it's going to be cut at some point completely.
Our macro people team, when they are organizing to do the monitor testing, they don't necessarily go alone as partners. They go together with MOH staff. So when the services are being provided by MOH staff. So this translates into, say, the capacity to do those activities are there. But what is lacking is the logistic part. Transport the team to such a, because they've been taken at a late hours, how they can support them. That's the only challenging part. So yeah, can be a gap because we can't manage to go. We don't have all that support. So maybe we can anticipate that.
During that period, those people that were initiated in ART, they were not followed up. So it's difficult for them to follow them right now. And even for the viral load testing, like those that were trained, the HSEs, due to the reluctance, negligence, we were not able to do the viral load testing. Even the EID testing was kind of interacted. They were trained, but they were not practicing more, so they were not competent enough.
Now, there are a lot of measures that Ibn Soviet is putting across, just to make sure that even if partners goes out of the district, there should be sustainability of those activities. So one of them is what he has mentioned, that is the MOH that takes lead in terms of service provision. I'm also glad to say whenever we're doing the activities all along, even at the drop-in centers, there's most MOH personnel that is also there. So that should, in case macro moves out, or should in case EGIPAF goes out of the district, or should in case Trump says no more, we're completely stopping now, there should be kind of an interaction of services. So all along, there have been issues of that. Yes, you mentioned of that there have been some reluctance in terms of maybe some others personnel, they were engaged with some other activities with the feeling that there's somebody else that is also assisting. Yeah, so I hope now there are a lot of measures, and the MOH is working on memorandums just to make sure that such kind of shocks that was there before, they shouldn't happen in the forthcoming.
For Zomba, we are doing great. Okay, but I see that our district is on top in as far as HIV is concerned. Is carrying the flag, is raising the flag in Malawi. So whilst we're doing the best, and we are crying for the partners to come in and support the MOH, I think that it is also good for partners, EGPAF, Lonja, my colleague. The team also is already doing a great job, as already earlier on that they have a robust healthcare workers that are also doing the great job. But I feel that since it's like we are doing good on the part of the provision of the services, but on the preventive part, I think we are way behind.
If we are trying to analyze it, it should be looked at maybe in a broader aspect than just maybe the provision of medication and the like. I do know that there have been a lot of job losses, particularly for some healthcare workers who were benefiting from the funding from the USAID. So I know several, now they are not working. So that's an impact on itself, bringing in the economic aspect to the discussion, to say that people who were in contracts, some of them maybe 2 years contract, 4 years contracts, now the contracts just got terminated. That's a huge impact in the society. But also, apart from that, also to look at the our colleague from the DHO was saying about our health facilities being friendly to the particularly key populations. Myself, I deal with the LGBTI population.